Thank you for joining us for today's ECG webcast, Optimizing APP Performance Through Supportive Operations and Compensation Incentives. I'm Jamal Campbell, an Associate Principal at ECG, and I am pleased to be your moderator for today's session. Many organizations are expanding the APP footprint within their care teams to improve patient access, replace an aging physician workforce, and meet other strategic and business objectives. In doing so, organizations are focusing on operations and compensation for APPs to maximize their investment. Today, we will explore the limitations and drivers of operations and incentive alignment for APP performance, and our ECG provider experts will discuss the state of the industry as it relates to trends and regulations, the impact of APPs on practice economics, common operational challenges and how to address them, APP compensation design, and the fair market value implications of APPs. Before we introduce today's speakers, let's go over a few details about the webinar. It is 60 minutes in length. The first 45 minutes of the program is a presentation, followed by a 10-minute question and answer session. Everyone should have received a copy of the session handouts, but if you are a late registrant, you can download the handout in the handout pane on your screen. Note that attendees are participating in listen-only mode, but if you have questions, you can type them into the question pane located in the toolbar on the right of your screen at any time. At the end of the formal presentation, our speakers will answer as many of your questions as possible. Finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete this survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Now let's meet our speakers. Josh Halverson is a principal at ECG and leads the firm's provider financial services practice. He is a trusted partner and advisor to the leadership of hospitals, health systems, academic medical centers, and physician groups. With more than 15 years of experience in healthcare strategic and business planning, hospital operations, and physician organizational development, Josh understands the challenges that providers face in a volatile and ever-evolving healthcare marketplace. Josh has specific expertise in physician organization development, compensation planning and incentive design, and service line physician organization management, which has allowed him to improve organizational performance, facilitate growth, and optimize service line and physician group functioning. Welcome, Josh.
Thanks, Jamal. Glad to be here.
Our next speaker is Brandon Colley. Brandon's diverse background in provider financial arrangements and transaction advisory services enables him to identify financial risk and opportunities for organizations considering compensation redesign, consolidation, integration, or facility service line development. Brandon has worked with a wide array of provider organizations on financial-related matters, allowing him to understand relationships between entities throughout the entire healthcare delivery system. As a manager in ECG's provider financial services practice, Brandon focuses on facilitating organizational change and assisting with the design and implementation of system-wide provider compensation structures, physician alignment strategies, and value-based transition planning. Welcome, Brandon.
Thank you, Jamal.
We have a lot to cover today, so I'll now turn the program over to Josh.
Thanks, Jamal. We are really pleased to be here. Just quickly about ECG. ECG Management Consultants has been around for about 45 years, and we are the leading healthcare advisory firm that provides services to providers of care, which include healthcare systems, hospitals, physician organizations, academic medical center, as well as payers. We're very pleased to be viewed as an expert in this space. On the next slide, we provide a full suite of services across strategy, enterprise design, capital asset planning, other types of things, financial management, operations improvement, technology solutions. Digital health is a huge topic of ours right now. So within the provider space, ECG provides the full continuum of care, and our focus is really creating customized solutions that meet our clients' needs. We view our clients to be long-term partners of us, and is the space that Jamal, Brandon, and I are in, provider compensation planning and design. There's nothing more intimate and sensitive than those kinds of arrangements. So we have a lot of experience doing design work for organizations across the country. Page 5 describes our agenda for the day. Jamal went through these at a high level. Before we get into this, I want everyone to view this as kind of the first in a series of presentations and interactions where we will be addressing topics associated with APP compensation design and fair market value. This is an emerging topic area that unfortunately doesn't have a lot of data, and the data that is available is immature. So we are taking our survey information, both from our compensation and cost information, and turning that into actionable data and information that can be used to inform strategies around APP recruitment, utilization, as well as compensation design. So we'll talk a little bit about the state of the industry today, go through some of the key things that we're seeing in terms of our surveys around the practice economics, and talk a little bit about operations. We'll describe what we're seeing around APP compensation, and then Brandon will conclude this by talking through some fair market value implications that are really key as we think about the evolving strategies that organizations use around APP utilization. So let's jump right into the state of the industry. On page 7, we describe the drivers that are really organizations are thinking about when they think through their APP strategy. Usually, organizations are seeing APPs as a way to increase access to their patient populations and substitute for physicians in areas where they have shortages. We are seeing in lots of places growing supply of nurse practitioners and physicians assistants. We are also seeing their roles expanding and viewing themselves, and the industry viewing them as more providers of care rather than maybe the historical view of just a traditional extender or even nursing resources. We do think that APPs have the potential to increase physician efficiency by allowing both provider types to practice at the top of their license. Again, driving patient access and provide a lower cost alternative for physicians who are aging out and exiting practice. One of the key statistics that we're investigating is what it takes to replace a physician that is leaving or exiting practice with a physician who is entering practice. As we've observed, the practice styles and productivity of those two physicians is very different, and the professional expectations of those entering markets are different than those who came in a generation ago. APPs are a solution to the gap of the high production that aging physicians traditionally have had versus a lower production that new physicians are indicating. So let's go to the next slide. On slide 8, we talk a little bit about the continuum of APP and the jobs. So we have observed that the job of the APP is rapidly evolving, and we categorize them loosely across a continuum. On the left-hand side is a practice extender model where APPs are really in a physician support role. Sometimes what we observe in this situation is that the APPs are often, underutilized in terms of the capacity and capability that they bring. In the middle, we see more of a collaborative provider where this APP works very closely on a care team with physicians, and the physicians and APP work together to determine a patient's care plan. Often, these APPs will see patients independently with some supervision of APPs. As we'll talk about later, a real driver of how APPs are utilized is determined based on state regulations that either expand or limit the APP scope of practice and allows them to do different things. the far right of the continuum represents an independent provider, where an APP functions very similar to physicians and provide care very independently. Again, the regulatory regime of a state really allows APPs to operate in this independent status. One of the key things that we have observed, though, however, that isn't spelled out on this chart is a key determinant of how an APP is utilized is, frankly, the way the physician utilizes that APP in a practice. And so even within specialties, within the same organizations, often within the same practice, there's such a variety of how a physician sees and utilizes an APP that the job of the APP really varies even within specialty. So that's a key distinction that we'll be talking about in this presentation, as well as future ones, about how lots of organizations are trying to resolve some of those variances. Going to page 9, we wanted to at least mention and illustrate some of the differences between states and how APPs are viewed in regulatory and statutory situations. Washington, for example, provides a full independent practice authority to NPs, and there's some supervision of a PA that's determined at a practice level. California has more restriction, and physicians collaborate, and an agreement is required. And you can see that PAs are also really required to provide some. Physicians are providing oversight to APPs in terms of prescription and other types of things. Nebraska, you can see, is also different. The transition to independent practice is required for NPs. There is a prescriptive authority is determined at the practice level for PAs. And so the point of this is we are observing that these regulatory regimes are evolving. As everyone is probably aware of, the various state societies of PAs and NPs are really pushing state legislatures to expand the scope of practice for APPs. There are some countervailing winds, though, from the physician societies that often try to limit APP scope of practice and keep them restrained. So we expect, however, that the trend will be to expand the scope of practice for APPs. On page 10 is a visual of the current regulation in states that across the country that show how full practice versus restricted practice APPs are by state. We've done some analytics on this. On page 11, we are comparing, for example, on this page, productivity of nurse practitioners in states that have the ability to provide full practice versus restricted or reduced practice. And as you would expect, NPs in states that allow full practice are much more productive and see higher acuity patients than their counterparts in states where there's restriction and reduced practice. And I'll move forward to the next slide. PAs are kind of a similar story. You can see that there's more collaboration requirements and defined scope of practice in the PA world. Page 13 shows a similar kind of analysis where we are actually taking productivity levels and comparing them by state. Again, directionally, the same story applies. When there's a broader scope of practice, more autonomy really results in higher levels of productivity. Brandon will talk in a minute about the implications of this, but when we think about how surveys, compensation and production surveys, are used to inform compensation plans for APPs, this really needs to be taken into account. And when we think about the productivity expectations and other elements, we really think that these state regulations have a an impact that need to be accounted for. So Brandon, I'm going to hand it over to you, and you can take over and walk through some of the findings around our practice economics.
Thanks, Josh. On slide 15, one trend that we've seen in our survey data is an increasing trend in APP compensation with a decreasing trend in RVUs. And a lot of that is likely due to some of the survey challenges that we have in the APP realm right now. As Josh mentioned earlier, there is significant variation in how APPs are utilized not only organization to organization, but within the same organization and same specialty practice to practice. And a lot of that is driven from physician influence as well as some of those state regulations. And so the variability in APP productivity really creates a challenge here as far as benchmarking and understanding what is an appropriate level of productivity as we're looking at different APPs. Moving on to slide 16, we did see kind of a sweet spot in our cost survey data on APP to physician ratios and where the investment per physician is minimized. And we saw that around the quarter to a half APP per physician. Now, I don't want that to be construed as being the kind of end-all be-all, because there are organizations at the higher end of APP footprints within their practices that are able to be successful and minimize that investment per physician. And some of the reasons that you might see higher investment as organizations add APPs, if we look at slide 17, we have a few issues around where organizations can kind of get into trouble in expanding their APP footprint and erode practice economics. Some situations might be an APP is added to meet a specific access need or other patient care to where it doesn't necessarily lead to a full productivity and billable activity. There's also situations where APPs aren't utilized at the top of their license, and this gets back to some of the issues around physician influence within those practices. And then there's also potential at higher ratios that the burden of a physician to manage those APPs is at a level to where they're sacrificing their own productivity. And this is probably more prevalent, particularly in those states that have some of the more restrictive regulations. And then sometimes organizations are adding APPs without necessarily doing a needs assessment and understanding the implications around supply and demand before they add additional capacity. Moving on to slide 18, if organizations are wanting to drive performance through APPs, and one of the ways that they're looking to do that is through an APP compensation redesign. One of the things that's imperative first is to address some of these operational limitations, because if you're starting to move towards more variable at-risk pay for compensation, it's essential that there is consistent utilization of those APPs across the system, so they have an equal opportunity to perform within those variable components that might fall into the new compensation. And so some of those operational limitations that we'll cover in the following section include physician influence, clinical scheduling, competition between physicians and APPs for RVUs, as well as the APP reimbursement levels and the availability of some of the performance measures at the APP level. So moving on to the next section, we're going to start by talking about some of the physician influence. As you know, physicians oftentimes are the key determinant in how an APP practices within an organization in their practice. And some of the ways that this can be mitigated is organizations that are trying to push and expand their APP footprint are developing guidelines, and those guidelines are then kind of shared and agreed upon by physicians and APPs, defining what is actually in scope and what APPs should be doing on a daily basis. And so this is to kind of try and minimize some of the extender type of activities that aren't necessarily revenue generating. And this gets into some of the education too. A lot of times APPs come in and have the physician telling them what to do, and they don't necessarily know or push back to do other activities. And so that's where some of the education can come into play. And then one of the ways to help mitigate it is to move towards a system level scheduling. And so this is to alleviate any concerns of over block scheduling, to allow the APP to do activities that aren't necessarily at the top of their license. And if we move into slide 21, we have a few snapshots from some work we've done at other organizations to address some of this. Around the centralized scheduling, what this allows is when a new patient or existing patient calls in, that scheduler can see across the board what providers are available. We can standardize the schedules across physicians and APPs, and they can direct based off the patient need. If they're a new patient or higher acuity patient, those can go towards the physicians, which would then help bolster the physician productivity, and existing patients that are at the lower acuity end can go towards the APPs. And so that way you're kind of directing patients in the most efficient and appropriate manner. And so that can help keep APP productivity at where it needs to be and minimize some of the physician influence as far as what activities they're doing by having those schedules built out and blocked for actual patient care time. If we move into slide 22, one of the other big challenges that often comes up in organizations is physicians' fear of competition for productivity. Given that physicians are commonly on productivity-driven compensation plans, they don't want to be at risk for losing any dollars to an APP. And the way to mitigate this is to really monitor patient access and recruit and implicate those into the recruiting decisions that are made. And then also, if there is imbalances that exist around supply and demand, it might make sense to move APPs between practices just to meet the appropriate level of demand. And then also another thing that organizations think about is incorporating team-based incentives into physician plans. So this could be like a panel size component that looks at the team-based panel as opposed to individualized panel sizes. And the thought here around the physician competition is that there really should be enough demand in any one practice to keep a physician and an APP fully productive. And if there isn't that level of demand, then it doesn't make sense to necessarily add an APP there, because then you're going to have the excess capacity and erode the practice economics. If we move to slide 23, these are a couple snapshots again from some of our client work. And what we have is we can look at average appointment lead times as well as schedule adherence rates. And so, if you have a long lead time but a poor schedule adherence rate, sometimes that you can mitigate some of that with the standardized scheduling and centralized scheduling teams that will help bring down that lead time and get all those patient blocks filled. But if it's really just a lead time issue, then that might make sense for bringing in another physician, another APP to mitigate some of that access issues. We can also do market needs assessments where you look at the aggregate market of new patient wait times, as well as projections around market growth and succession planning, so the number of physicians in the market that are physicians or APPs in the market that are over the age of 60. And so that allows you to try and better suit your practices and staff your practices with the appropriate mix of physicians and APPs. So if we move into slide 24, the next challenge is around non-productivity performance tracking. A lot of times there's a lot of robust data within systems around physician level type of measures, quality, value, panel size, things like that. But there might not be as available or accurate in the APP world. And so we'll work with organizations to help them discern the types of measures and what's available for APPs. And sometimes it might require some new systems or modifications to EHR systems to ensure things are tracked appropriately and attributed to physicians versus APPs appropriately. And if we get into slide 25, how we kind of look at the measure selection when we're working with systems to redesign their APP compensation, we typically have a set of domains that we look for, and those examples are access, quality and safety, financial stewardship, service excellence, and citizenship. And we really work with them to not only document what measures are actually available today and can be reported today, but push them to think about some aspirational measures. So these are things that might be good to have in a plan, but it might not be incorporated until maybe year 2 or 3. And one of the things to think about as we're incorporating non-productivity measures into APP compensation, given that their current compensation environment is heavily fixed, this is a very new element for many APPs, and so it's usually best to start small at 2 to 3 measures and allow APPs to get kind of comfortable with this new dynamic within their compensation plans. And so usually organizations can find 2 to 3 that are currently tracked and available and can easily be reported on as a starting point, and then moving out into years 2, 3, 4, etc., those measures can evolve over time as systems evolve, as reimbursement environments evolve. Those can grow and kind of shrink and dial up and down as it makes sense. Moving to slide 26, one of the other challenges that we've seen at many organizations is around the APP reimbursement. Oftentimes there's a significant focus on physicians and specific specialties in the renegotiation process with commercial payers, and a lot of times the APP element of those contracts is overlooked. And depending on what kind of language comes through, it can be very, very detrimental to practice economics if they're not being reimbursed at an appropriate level. And so as organizations are thinking about expanding their APP footprint, it's important that you review the contracts, validate any of the mechanics that are defined in the contracts, and then negotiate where there's gaps and it seems appropriate. So if we move to slide 27, these are a few provisions that we see pretty commonly across the industry. Starting from the left to right, it's kind of the most beneficial to the least beneficial. A lot of contracts will be just completely silent to APPs, and so that's kind of under the assumption that you have a single negotiated rate, and that rate should apply to both physicians and APPs. And this is one of those areas where it's very important that you validate that and actually pull claims data and ensure that you're being reimbursed at that rate that you negotiated. But that, if so, then that would be an ideal situation and not necessarily warrant any renegotiation. In the middle column, another provision is where APPs will be reimbursed at 85% of the physician fee schedule. And that would be kind of on par with how Medicare thinks about things, because they're also billed at 85% of the Medicare fee schedule. And so if you have physicians being paid at 150% of Medicare and you have 85% of that, the APP rate would be about 127% of Medicare. And so again, this would be appropriate and in line with how Medicare thinks about it, and wouldn't necessarily warrant a renegotiation. But on the right column here, what we see that is frequently snuck into contracts is that APPs are reimbursed at 85% of the payer's standard fee schedule. And the issue with that is that the standard fee schedule for most payers are generally modeled very similar to Medicare. And so you're effectively paying APPs at the Medicare rate. So if you have physicians that are at 150% of Medicare, and then you have APPs that are 85% of Medicare, that can have significant implications for organizations with a high APP footprint. And so now that we've talked about some of the operational challenges and things to think about and mitigating those, I'm going to hand it back to Josh to talk about some of the design and compensation elements.
Thanks, Brandon. Just to reiterate for everyone what Brandon was saying, I was at an organization 2 weeks ago, and we were talking about APP compensation design and how their strategy was to increase the number of APPs very dramatically. Unbeknownst to them, and through our data requests, we were able to identify that their reimbursement for APPs for two of their pretty significant payers was pretty low. And so that checkpoint of being coordinated with managed care departments when negotiating rates and coordinating strategy around APP growth is something I think is really important and sometimes gets left off the table when people think about this. So jumping to page 29, the compensation plans for most APPs current state is, I would say, very heavily fixed, where compensation is either mostly straight salary, as you can see on the table. It has some variation depending on the whether it's a PA or an NP. But some organizations do, introduce risk elements in their compensation plans. Typically, when they do, it's much less than 50% of total compensation is at risk. There's a few, but very small numbers of organizations that have variable compensation for APPs that represents more than 50% at risk. So one of the challenges, or several of the challenges with these kind of configurations, is that large, fixed compensation plans just inherently don't align compensation with the high-performing APPs, and that misalignment just creates, inequity issues and other types of things that are problematic in attracting and retaining APPs. Over the past, I would say, decade or so, APPs have elevated themselves within the industry and are viewed much more as providers of care rather than their historical kind of roots of extended nursing personnel. So we do think that the compensation plans need to migrate to things that are more contemporary. On page 30, we do show that the typical compensation constructs that we recommend need to acknowledge the differences in APP role. And so you can see, again, going left to right, practice extender has a much kind of higher level of fixed compensation. And this makes sense because these APPs have their job is much less focused on production, for example. They don't have the opportunity to do practice maybe independently. We do like to introduce variable compensation and mostly around value-based elements in these kinds of situations. We think it's important to synchronize performance-based culture, if there is one, across both physicians and APPs, and so it's valuable to have these elements of variable compensation even in practice extender situations. The other extreme is a much more independent provider where an APP is billing independent of physicians. It makes much more sense to have perhaps a lower base level of compensation and introduce a larger proportion of productivity elements around incentives, as well as, again, continuing value-based variable compensation in those situations as well. The collaborative provider is often kind of a hybrid where there are elements of production. There's also a value-based, but perhaps a higher fixed compensation element. We do very much view these compensation models as dialing up and down various configurations to meet the needs of the organization and the configuration of practice. As we all know, the more risk or variability in compensation you introduce, the more anyone, APPs included, want to have control over those variables. And so back to what we were talking about earlier, one of the most nuanced discussions we have is when we introduce productivity elements to an APP compensation plan and they don't have control over their production because of physician preferences or other circumstances that limit APP's ability to actually produce, that you're creating conflict and tension within the organization. So, we believe that compensation and operations absolutely intersect, and developing a compensation model that aligns with operational realities is something that we think is a really important consideration. We also think that these models need to be flexible and should and will evolve over time. So as APPs and physicians get more consistent and standard about how they practice together, these elements of compensation should evolve and mature. On page 31, we illustrate some of the key questions that we often talk about when we're developing compensation plans for APPs. Because we do think that there are elements of fixed compensation, it's really important that we think about, what specialties that element should be applied to. To what degree there should be differentiation between specialties. Again, when we think about the supply and demand and skill set of cardiac surgery APPs or PAs, for example, versus primary care, while there's some data around the specialty-specific compensation approach, thinking about that differentiation and calibrating it to represent, different skill sets, different supply and demand in a market gets to be very challenging and difficult. Some places say, hey, we're going to have a standard approach that's based on level and seniority or tenure. Other organizations put more differentiation based on specialty. We think that like physicians, the jobs will require some differentiation by specialty, and that differentiation will be measured and data will be available in the very short term in a more mature way. The key question that we often ask when we think about fixed compensation elements is what performance expectations are built into that base, and being very specific and clear about those expectations is very useful and necessary in order to manage just the enterprise of care delivery. In terms of the other elements, to us, a couple of notes that I'll mention on some future slides are, when we think about clinical activity, what measures of production should be used? Do we think about, linking compensation to RVUs, to collections or charges or some other measure of clinical activity? Again, to us, this really is important to understand what opportunity APPs have in generating either their own or shared production. And we'll talk about some value-based considerations in the next couple slides. The one note that I did want to make on page 31 is that there are more and more APPs are participating in administrative roles. And again, we would say the same type of principles that are in place for physician administration should be applied to APPs in terms of understanding the time requirement for administrative roles, calibrating compensation for that time appropriately, and using methods of tracking that information and time spent on those activities and holding people to account for their activities. I'm going to go quickly through the next couple slides. On slide 32, we talk about what level of performance. I will say that more and more we have a bias towards more group performance mechanisms to really see APPs and physicians as care teams. Obviously, the trap we want to avoid is kind of a free rider effect, where we need to have a reasonable balance between individual performance and grouped performance, so people aren't getting subsidized or their performance is being shielded from other expectations. But at the same time, we think it's really important to foster the group team-based approach. On slide 33, and I'm just going to throw this up as examples of potential metrics. As Brandon mentioned, we think it's really important to keep it really simple. And often organizations are really tempted to get pretty advanced and intricate in their measures. Even more than physicians, APP variable compensation is a relatively new construct, and so we think it's important to keep things very easy. People can understand what metrics they're going to be held account to, and those metrics are reliable and frequently reported. So it would be very common to start with some what I will call rudimentary metrics and then evolve over time. So Brandon, I think a key topic around this is how we think about fair market value. So I'm going to let you take the rest of the slide on that section.
Yes, thank you. There is quite a bit of legal risk on both the physician and APP side here as we're thinking about fair market value and commercial reasonableness. CMS states that if a physician directs or controls the referral activity of an APP, even if the APP actually makes the referral, that referral can be attributed to the directing physician, which can create some stark implications. There's also the anti-kickback statute that broadly applies to all individuals, physicians and APPs, that needs to be taken into account. And then there's situations where physicians are receiving payments for the oversight. There's the typical FMV concerns around physician compensation that need to be evaluated there. So moving into slide 36, as we think about evaluating APP compensation specifically, it's really no different than how you would approach a physician. There's going to be a time-based element or FTE approach. There's going to be a collections or reimbursement-related approach, as well as a productivity or RVU approach. And so, looking at these practice extender to independent providers, they can almost be replaced with, on the left, being a coverage type of physician specialty to maybe primary care or the productivity specialties on the right. And so you really evaluate them no differently than physicians It's just a little bit different as far as the different risk elements that are in play and who's at risk for what. Moving to slide 37, as we think about how to evaluate physician oversight compensation, there's really three approaches that we do. One is the time-based approach, and so that's looking at the amount of time a physician is spending for those oversight activities and attributing a value in excess or in situations where they have an excess supervision burden. There's also the distributed productivity approach, where we look at basically the team of APPs and physicians, their aggregate compensation and aggregate performance, RVUs and collections, because a lot of times what they're able to achieve from a performance level as a team is greater than what they could do as an individual provider. The last methodology is the net income methodology, and that really looks at the practice economics. And one of the things that's unique to this one is it can incorporate elements like capitation or other risk-based contractual arrangements that practices have. And so it becomes very important in those practices that have those high proportion of risk-based arrangements in understanding what the true economics of those are and how the APP plays a role within that. Lastly, on slide 38, as organizations think about if it makes sense to even pay a physician for oversight, this is kind of a flow chart and some simple questions to kind of ask yourself. But generally, if a physician benefits through productivity or other types of things from the APP's presence, then it doesn't necessarily make sense to pay for the oversight on top of that, because they're getting those dollars through other elements in their own compensation plan. But some of the other questions to ask is, if the APP frees up time for the physician to do other activities, and are those activities actually beneficial to the health system, like patient access, quality of care, things like that? And then does the APP, are they working at the top of their license? And if they are their activities benefiting the health system in a similar way? And so those are some of the things that you can think about as when it actually would make sense to even pay a physician for oversight. Because like in a surgical situation, the APP is doing surgical assist, patient follow-ups, things like that, where they may not always be generating RVUs themselves, but they're bolstering the physician's RVUs, which would then be paid out through the physician's plan. So those are some things to think about as far as when to pay and when it makes sense to just stick with the current physician compensation plan. So that pretty well wraps up our plan. I'm going to hand it back to Josh for some closing comments.
Yeah, thanks, Brent.
It looks like Josh is having some phone issues, so I'll wrap it up here. Just to bring everything together, organizations, as they're growing their APP footprint and thinking about redesigning their physician or their APP compensation, it's really important to take it from a two-pronged approach and ensure that the operations are in place and optimized to allow the APP then to have this new compensation plan that drives value for the organization as well as themselves through these other variable compensation elements. On slide 41, we want to just give a quick advertisement here to some of the upcoming topics we'll be covering. We plan to have a few half-day workshop sessions that will cover various elements. One of them is going to be on the APP component, but then we'll also have topics on primary care, hospitalist-based specialties, and then some case studies around other situations that hospital leaders are seeing throughout the industry.
And Brandon, I'm sorry I missed you earlier. To me, I wanted to make sure that people understand that these are going to be extensions of this conversation, and we will be getting into, situations of strategy around APP recruitment, how APPs impact the physician and provider enterprise in terms of the economics, and some of the novel things that we're discovering in terms of break-even points and other types of things that we've been able to identify through our analytics. So these are going to be really useful sessions that will address questions that we're seeing across the country. I'll conclude there and just say thanks for participating and hand things over to Jamal to kind of open the question and answer period.
Great. Thanks, Josh. Before we move on to some of the questions, a reminder to our audience to please continue to enter your questions in the questions pane, and I will ask as many questions on your behalf as time permits. With that in mind, our first question is related to compensation for the oversight of APPs, and do we have any guidance on how much physicians are typically compensated for those responsibilities?
Let me address that, and that's a complicated question. So we avoid trying to have rules of thumb because every situation is different. The guidance we do give is what Brandon was alluding to. There is absolutely time required for physicians to oversee APPs. There are the physician is holding some risk. However, what we do see is often organizations don't recognize, especially in an employment situation, don't recognize that APPs are employed by the health system and attribute all the benefits of an APP to the physician through compensation, while not recognizing that the organization is holding the risk and therefore should have some sort of return. So I think one of the challenges that we've seen is the calibration for APP supervision payments may be too high relative to the risk that the physicians are holding. With all that said, we do, as Brandon mentioned, have approaches around net income approaches and kind of shared productivity that allow us to really look at the situation and derive a fair market value amount that is reflective of the economics of the practice.
Great. Next question, have we seen any significant differences in academic medical centers? The comment is that APP activities sometimes vary from, medical student type activities to those with fellow type activities. Any thoughts on that?
It's interesting. I was just at an organization on the West Coast talking about this very topic. Often residents function as kind of as APPs, and so usually there's a substitution effect that happens. But more and more with resident caps and other types of things, I think academic organizations are increasing the number of APPs that are being utilized, and again are facing some of the very same challenges that their non-academic colleague organizations are facing in terms of recruitment and compensation. So we are absolutely seeing APP presence in academics increase and expand.
Thanks, Josh. Next question is related to the supervision of APPs, and specifically, this person says their organization is struggling with the number of APPs that one physician can or should supervise. Some supervise the entire complement of APPs within the specialty, while others may only have responsibilities for one or two. Is there any best practices in terms of what makes sense around the supervision and the number that should be supervised by physicians?
Brandon, why don't you jump in with kind of reiterating some of your analytics on that, and then we can talk a little bit about scope of control.
Yeah, some of that gets back to the how burdensome it gets for a physician, and so at the very extreme levels, it's almost like a physician is spending the preponderance of their time overseeing APP work, and there's little billable activity that they can generate out of that. And at some level, it probably makes more sense to put a cap. We've worked at organizations that put an upper limit, anywhere from 3 to 4 APPs per physician, to just mitigate some of that. And so the physician can still be doing the patient care that they need to do, as well as have an adequate burden and not overburden from the oversight activities that they'll have to do. And I mean, there's a lot of financial implications too when you have an APP predominantly being the ones generating the revenue, while the physician is predominantly doing the oversight, just around the reimbursement differences that are in play there as well.
And that's where I was going to jump in, and maybe as a teaser for a future conversation. We've seen many organizations really expand and leverage physicians with multiple APPs, pretty high numbers. And when you look at the collections and the true economics of the practice, you actually sometimes find that you're often better off with fewer APPs and more physicians. And so there is an economic question on this, and sometimes there are circumstances where you can't recruit and find physicians, and so you need to use a substitution of APPs. But I think it's a much more nuanced conversation than perhaps organizations are thinking about when they really open the floodgates to APP recruitment.
Great, thanks. We have time for one more question, and this next one is related to APP utilization. We spoke a lot about potential challenges that exist concerning consistent deployment of APPs within a specialty, and how this creates some challenges both operationally and as it relates to developing some consistent compensation methodologies. This participant said that within their organization, each physician appears to have a different personal philosophy on APP usage, and wants to know what steps they can take to push the organization to create more consistent utilization within a given specialty.
Yeah, and Brandon can jump in on this too, but what I would say is that is very much the case, and I think as APPs continue to mature, as they become viewed as part of the team in both training physicians and APPs, I think this will settle itself over the next decade or so. What we have found most effective, however, is that the organization needs to take a more philosophical and directive role in this, and to do that, obviously, there needs to be a strong why are we migrating to more consistent approaches, as well as sharing of data, and often those data are the first time people see how APPs are utilized. The scatter plots or the bar charts are all over the place, and over time we do see the Hawthorne effect, which is once it's monitored, people's behavior changes slightly. But I would say that it's really important to establish a philosophical principle as to why we are trying to move more toward a consistent approach. Brandon, I don't know if you have any other thoughts on that.
No, I think once the philosophical direction is nailed down, then it's really more tactical elements around kind of the education, developing guidelines, and things like that to really ensure that the APPs are being used appropriately.
Great, appreciate the responses. We have come to the end of our program. I would like to again thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information provided in the handouts. One final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a great day.